All right, good afternoon, everyone. My name is Gerald Jackson, and this is my poster presentation on the effects of targeted temperature management on post-cardiac arrest patients. And so just a brief introduction, Nielsen et al. In 2019 posted a study that compared the effects of targeted temperature management at 33 degrees Celsius and 36 degrees Celsius. And this was a known protocol for since the 90s, but after this study, they found that the survivability and neurological outcomes of the therapies for both temperatures were similar. And this led to a huge debate in the medical community regarding what the optimal targeted temperature management therapy should even be, or if there even should be one in the first place for adult comatose patients who achieved a return of spontaneous circulation after cardiac arrest. And so this was a protocol that was basically used for patients who post-cardiac arrest, they returned, or they had a return of spontaneous circulation, but they had a GCS or a Glasgow Coma score of less than 8, so they were probably comatose. So this main protocol was to prevent the inflammatory factors to enter into the brain and just lead to an increase in anoxia conditions. And so this main research question that we're going to explore in this poster is, does targeted temperature management result in a significant improvement in survivability rates and in neurological function? So the hypothesis I conducted was that targeted temperature management does significantly improve a patient's neurological and physiological function as measured by prognostic factors. And the peacock question would be, in or among post-cardiac arrest adult patients, does hypothermic targeted temperature management versus baseline standards of normothermic care result in the reduction of neurological disability and survivability after 6 months discharge? And so many of the studies that I explored indicated that they studied records of post-cardiac arrest patients undergoing targeted temperature management that to retrospectively analyze and determine optimal prognostic factors to measure the protocol's efficacy. They also studied variable forms of inpatient continuous monitoring for their vital signs and other hemodynamics for the researchers to determine if a relationship between these prognostic factors and neurological/physiological outcomes were present for a patient experiencing TTM. And for various studies, researchers also performed telephone interviews with these patients 6 months after discharge to determine if a deterioration of cognitive and neurological function were present. So to review the literature, I used multiple databases through the Azusa Pacific University Library that included ScienceDirect, Medline with full text, cumulative index to nursing and allied health literature, plus with full text, Academic Search Premier, Academic Search Index, Springer Nature Journals, direct of open access journals, and PubMed. The keywords that I used were targeted temperature management, post-cardiac arrest, return of spontaneous circulation, and systemic hypothermia. And modifiers, the modifiers I used included publishings within the last 5 years of 2022, since publication, having a full text availability, being peer reviewed, and written in English. So the first search that I had gave about 3,629 results. So I decided to narrow the search further by adding comatose patients, and that narrowed the results to 289 searches. After that, I added the other keyword being adults. Eventually, that led to the search narrowing down to about 58 results. And after reviewing the results, I used 10 as they were more relevant to the current peacock question. In regards to the critical appraisals, we used the Johns Hopkins appraisal tool to appraise our studies. Here are some of the quantitative and qualitative articles that I found. These were the most useful for my peacock question. Chen et al. At 2019 conducted a level 2 quasi-experimental study with a retrospective analysis for 88 consecutive comatose cardiac arrest adult survivors who went through TTM. And he basically did continuous invasive serial hemodynamic monitoring at a critical care cardiac intensive care unit. And basically, these patients were undergoing targeted temperature management while having an invasive hemodynamic monitoring inside, particularly a pulmonary artery catheter. And while other hemodynamics remained as predicted or stagnant, they found that with the cooling, they found a cooling associated enhancement in cardiac contractility, and they supported it with a Frank-Starling diagram that revealed a left upward shift of contractility estimated from the baseline upon cooling conduction. And so, while there still needs to be more studies on this, because of the small sample size, and future studies need to have a larger sample size to confirm this, they're predicting that there is an association between TTM and left stroke work index or left stroke cardiac contractility. So I thought that was very interesting. I also used Connor et al. 2021 because he conducted a level 2 quasi-experimental retrospective analysis to determine a relationship between neurological outcomes and heart rate in post-cardiac arrest patients undergoing TTM. This one had a larger sample size of about 432 patients, and they found through continuous monitoring of their heart rate via cardiac monitor, they found that 85% of the patients who were considered to have a favorable neurological outcome scored by the CPC. CPC stands for Cerebral Performance Categories, and it's a main subjective measurement scoring system, and they used it to determine which patients had a favorable neurological outcome, and then they read the heart rate. They found that 85% of the patients with a favorable neurological outcome had a mean heart rate range of 60 to 91 beats per minute, with the p-score being less than 0.001. And so that's interesting as well, because that means that keeping the patient at a normal cardiac range would indicate that there's an increased amount of contractility going into the brain, and that helps preserve neurological function. For the short term at least, long term still needs to be studied. A very important study, Nutma et al. 2022 conducted a level 2 non-randomized quasi-experimental study with a post-hoc analysis of a prospective cohort study on continuous EEG monitoring just to determine the effects of hypothermic targeted temperature management. And so this was important as well, because they were able to have the objective factors of continuous EEG monitoring to help, as well as the CPC scoring mentioned in the previous study, to determine or to help categorize these patients in regards to favorable neurological outcomes. And then they were able to determine the effects of targeted temperature management this way. And so what they found was that all patients with severe encephalopathy, or they found that patients with moderate encephalopathy had a great outcome of treatment when using targeted temperature management. Now, the effects for severe encephalopathy and mild encephalopathy still needs to be studied, but they did find a significant improvement in the patient's neurological outcomes for a patient with moderate encephalopathy. Moving on to the qualitative part of the studies, this more focused on the patients who had, or post-cardiac arrest patients who were discharged, and this is regarding more their cognitive function after discharge. So beginning with Karo Kodon et al. 2018, he conducted a level 3 qualitative study that aimed to assess long-term cognitive and functional outcomes of cardiac arrest patients treated with targeted temperature management. And so what this author found was that patients who undergone targeted temperature management, while still needs to be compared with baseline, they found that 43% of the patients had experienced a new memory-related disorder after discharge. Now, previous studies have already indicated that there was a decrease in neurological function. So this part is not surprising, but I think baseline still needs to be explored in Karo Kodon's study. Now, moving on to Evald et al. In 2019, he conducted a level 1 predefined cognitive post hoc study where he kind of went further than carocodon and used neurological and cognitive assessments to determine their cognitive function 6 months after discharge for these post-cardiac arrest patients undergoing TTM. And so this study was done with 2 different hospitals, with 2 different TTM protocols. One protocol being that the TTM maintenance period of TTM was at 24 hours, and then another hospital where the TTM maintenance period was 48 hours, and they determined the cognitive function that way. So for these patients, 6 months after discharge, telephone interviews were performed to assess the patients with cognitive assessments. After going through various cognitive studies, including a CPC scoring system, they found that the patients who underwent a targeted temperature management maintenance period of 48 hours performed numerically better on cognitive function tests than the patients who underwent targeted temperature management for only 24 hours. They also found that patients who underwent targeted temperature management for only 24 hours were 3 times more likely to be cognitive impaired, which kind of is seen as well in carocodon, as his study, while it's not written there, his study only had targeted temperature management for a maintenance period of 24 hours as well. So moving on into the implementation strategy, the implementation of targeted temperature management was performed in various hospitals across the world. And this is because due to the current debate that is occurring, as I mentioned in the introduction, many hospitals have chosen to perform only normothermic treatment until there's significant evidence proving the efficacy of TTM. This could potentially lead to a decreased sample size. However, the researchers have successfully used existing data to convey significant benefits towards neurological outcomes for patients with moderate encephalopathy. And they've also found that certain prognostic factors could be used to further answer the PCOG question. In regards to the data collection tools and instruments, most studies utilize the cerebral performance category test scoring system to determine the patient's current neurological function in the hospital and also 6 months after discharge during the telephone interviews. And other studies that I went through would utilize prognostic factors such as heart rate and electroencephalography readings to determine the patient's current condition while undergoing targeted temperature management. In regards to the statistical tests, researchers would statistically compare data using the t-test for continuous data and the Fisher's exact test for categorical data. The effects of the cognitive test were calculated with multivariate regression analysis that's adjusted regarding someone's age and time from cardiac arrest to return of spontaneous circulation. TTM is an effective protocol as well for the preservation of neurological function for specific patients, such as those with moderate encephalopathy, like I discussed in Nutma et al. 2022. And this was significant because they had a p-value of 0.004. In regards to the ethical considerations, this project had ethical considerations regarding informed consent. The researchers provided information about the experiment, how the research would be implemented, how long the study would be, and then they achieved written informed consent from the participants. And they would assure that the participants, the information of the participants would be confidential, especially the collected information, and the participants had the freedom to withdraw from the study at any stage. Now for the conclusion, the implementation plan would help to answer the current PCOG question and provide a baseline framework for future studies to begin determining an optimal TTM protocol that will effectively help patients achieve favorable neurological outcomes. By deducing a correlation between key objective factors and the effects caused by TTM, these factors could be used in future studies to further prove the efficacy of TTM. Thank you for listening to my presentation. Hope you have a wonderful day.